Our group was tasked with understanding polysystemic immune-mediated disease. Polysystemic immune-mediated disease is more commonly known as systemic lupus erythematosus, SLE, or lupus. It is a complex autoimmune disease, a combination of type 2 and type 3 hypersensitivities that affect several species. While it is most common in families with a history of SLE, it can also appear sporadically in any animal. SLE is thought to be largely mediated by genetic factors. These genetic factors are also influenced by environmental and hormonal factors, including stress, drugs, and toxins. Due to this environment and genetic factor interaction, it makes understanding the cause of this disease more difficult. SLE typically appears in animals between 1 and 8 years of age, with the treatments and prognoses varying among individuals. Funny enough, lupus actually refers to the erythema that appears on the facial skin of humans and was thought to resemble a wolf's fur pattern. So, does this mean all wolves have lupus, since all wolves have fur pattern on their face? If only lupus was as simple as that. SLE affects a large number of species. The main species that are affected are humans, dogs, cats, and horses. In regards to humans, females are 4 times as likely to develop SLE than males. This gender bias is not seen in animals due to the common practice of spaying and neutering animals. In dogs, it is purebred animals that have a higher likelihood of developing SLE due to their smaller gene pool than mixed dogs. This relationship has been noted in purebred cats as well, and Siamese cats in particular are the most affected breed. On to immune mechanisms of lupus. There are 6 mechanisms that will be covered: genetic predisposition, environmental trigger, loss or lack of self-tolerance, production of autoreactive antibodies, release of inflammatory cytokines, and lastly, tissue and organ injury. This disease is attacking the body in multiple ways, so it will progress rapidly as tissue damage results in more autoreactive antibody and inflammatory cytokine production, which thus results in more tissue damage, recruiting more inflammation, and so on. Genetic predisposition is not understood very well, most likely due to the large amount of genetic loci that are involved. In humans, there are over 28 genetic loci associated, and in mice, there are more than 25 genetic loci. The loci that are involved are either susceptible genes or protective genes. The animal needs to lack some protective genes and have altered susceptibility genes. To illustrate the complexity of the disease, some of the associated genes that are involved are immune complex processing, TLR signaling, lymphocyte signaling, MHC, and FAST ligand. Fortunately, genome-wide association studies have been very helpful in understanding lupus's genetic cause. On to the triggers for SLE. Infections have been tied to the initiation and worsening of SLE. The reason for this is due to loss of tolerance, molecular mimicry, and the overexpression of type 1 interferon genes. Some of the common viruses that induce SLE are cytomegalovirus, Epstein-Barr, and parvovirus B19. Along with severe infections, severe diseases will also trigger SLE. Different types of drugs can trigger SLE, such as immunosuppressants, procainamide, and hydralazine. These drug-induced SLE cases are questioned if they are true SLE cases because in many cases, the patient recovers in a few weeks after the offending drug is removed and will only relapse if the drug is taken again. UV light is also a trigger, and some patients with SLE can develop photosensitivity. To conclude, what causes an animal to have SLE is having susceptibility genes that are altered, protective genes that are non-functioning, and lastly, an environmental trigger that will cause the cascading events. Moving on to how tissue damage occurs in SLE. It is due to type 2 and type 3 hypersensitivity reactions. With type 2, autoantibodies will act against hematopoietic cells and will lyse the targeted cell by activation of complement or cause phagocytosis of the involved cell. Now type 3 will create immune complexes along basement membranes and blood vessels. The antigens and autoantibodies then activate complement, which will cause an inflammatory response. The hallmark for SLE is the production of anti-nuclear antibodies, or ANAs, which will form immune complexes with nucleic structures. These anti-nuclear antibodies target a broad range of nuclear, cytoplasmic, and cell membrane molecules. They can even penetrate living cells to bind within and alter cell function, contributing to mechanisms of the disease other than classic or complement-mediated injury, which is why there is such a long list of clinical signs for SLE. There is a wide range of clinical signs associated with SLE due to the systemic nature of the disease. Some common conditions would be fever, general fatigue, malaise, joint pain or arthritis, muscle pain, weight loss, loss of appetite, headaches, renal failure, anemia, skin lesions, skin ulcers, and worst case, multiple organ failure. It should be noted that joint pain due to type 3 hypersensitivity response is the most common clinical presentation, with 78% incident rates, and skin lesions and skin ulcers are also extremely common at 55% incidence rate. Fever is the second most common clinical sign in dogs. Due to the large amount of diseases that present with fever, it is not a reliable clinical sign. To diagnose this disease will differ with humans and animals. In humans, the patients must meet criteria that was standardized by the American College of Rheumatology and Systemic Lupus International collaborating clinics in order to validate the diagnosis of SLE. There are 11 total criteria, and the patient must meet at least 4 to have a positive feedback or diagnosis. The criteria consist of many clinical signs that were presented earlier, but are more specific. For example, fatigue, weight loss, lack of appetite, and fever are not included in the criteria due to the large number of diseases having these clinical signs. Domesticated animals, on the other hand, do not have a standardized criteria, and veterinarians must use the combination of clinical signs, rule out infections, determine any predispositions, and then run an ANA test. The ANA test in particular is extremely important because anti-nuclear antibodies are pathognomonic for SLE. For dogs, a wide range of diagnostic tests must be run, which include hematology, biochemistry, urinalysis, imaging, joint fluid cytology, histopathology of the skin or kidney, and serum ANA determination. Cats should be tested just like dogs, except for the addition of testing for feline leukemia virus and feline immunodeficiency virus. The reason for testing for feline leukemia virus and feline immunodeficiency virus is because cats who have these diseases have had ANA positive tests, but the exact nature of this reaction is questioned if it is true SLE. Now, with anti-nuclear antibodies that are pathognomonic for SLE, then the additional tests don't seem entirely necessary. The reason for this is because some animals and humans do not have ANAs even though they do have SLE, and there are a wide range of diseases that have clinical signs that overlap with SLE, so those diseases must be ruled out. There are unfortunately no extremely specific treatments for SLE. The treatments often target decreasing inflammation and autoimmune reactions. So, corticosteroids and cytotoxic agents are used in combination to inhibit monocyte and macrophage action, as well as slow autoantibody production. The anti-inflammatory agents used are corticosteroids such as prednisone or dexamethasone, which also function as immunosuppressants. Steroids like these must be readjusted fairly regularly because the patient may develop tolerance to them. Immunosuppressants will also be administered, and some common examples of these are cyclosporin, azathioprine, and cyclophosphamide. We must be careful with these medications because they could potentially cause kidney or spleen damage. There are other treatments that can be used to help regenerate lost T cell function, which are levamisole and thymazine. Lastly, as I previously stated, limited exposure to sunlight will be encouraged because UV rays can cause flare-ups of the disease. Prevention is not foolproof, but steps can be taken in order to avoid or delay triggering an episode. Firstly, avoidance of sunlight is very helpful to prevent rashes and skin lesions. Exposure to ultraviolet light causes disease flare-ups in as many as 50% of patients exposed. Secondly, the avoidance of breeding animals that do have SLE due to the genetic component of the disease will prevent future dogs from developing SLE. Additionally, a study in humans suggests that the increase in allergies and autoimmune disorders is related to the decreased exposure to endotoxin during early development. So, a method of potential prevention could be adequate stimulation of the immune system at a young age. On to the prognosis of SLE. It is variable with a high likelihood of relapse, often with varying clinical signs. Luckily for dogs, they do have the best prognosis, while horses have the worst prognosis. Survival rates for patients diagnosed with SLE has increased over the years due to earlier diagnosis and improved management. I would also like to note there are many new drugs being created in this field and help moderate autoimmune diseases. A perfect example would be Humira for humans.